So I'm Amir, Noor. I'm one of the interventional radiologists at NYU. I think my talk should have a lot of overlap with Raj's talk, but I'll kind of emphasize the retrieval aspect of it. So we talked about the background, so we won't go too deep into it. So just to start off with some history about filters that I think Raj got into, the Greenfield filter was the first commercially widely used filter. Initially, the accepted indications were similar to what they are today. Thromboembolism with contraindication to AC, failure on AC, and hemodynamic stability that would not withstand further PE. Patients were followed up with 15 years of Greenfield filters, and there was a decrease in recurrent pulmonary embolisms followed out, but it was noted even at that time when these filters were first placed that there was a high degree of venous stasis and even ulceration in these patients. So this is the pre-spec one from 1998 from Nucusis. Basically, this was the first randomized trials that looked at filters versus not with no filters, and it was a big trial in that it showed that although there was a decreased occurrence of symptomatic PE, there was no change in long-term mortality. And further, a lot of these patients developed significant recurrent DVT, suggesting that the initial beneficial effects of placing these filters were actually counterbalanced by the negative consequences of them. Despite that, in 1998, there was a huge proliferation of these filters. Really, in the mid to late 2000s, there was a significant increase in usage. During that time, there was also an alarming trend that was noted in a number of literatures. This is from the trauma space, that at one institution, they looked at 125 patients that received retrievable filters. 70% of them didn't have their filters removed, which I think we see pretty commonly throughout all the different specialties. During this time also, there was the pre-pick 2 that once again emphasized that there was no effect on survival with these filters, and that there was this increased risk of DVT ultimately developing into post-thrombotic syndrome. Also in the vascular space, there was a lot of documentation on the risks involved with these filters, such as IVC penetration, filter migration, and filter fracture. Once again, there's a lot of epidemiology studies that go through that increased rate of filter placement. While all of that was happening, there wasn't really a concurrent increase in filter retrievals throughout the 2000s. So what ended up happening was just a lot more filters being left in a lot more patients without any follow-up. This all led to the FDA releasing a statement in 2010 saying basically all of us as physicians who implant these are responsible for the ongoing care of these retrievable filters. In 2014, they updated that, and then the part about retrieval is that they suggested each of these patients should have a risk-benefit profile given to them, and the suggestion is that 1 to 2 months after implementation, that profile should be done, and these filters should be removed at that time. The SIR, as Raj was saying before, came out with guidelines very similar, just saying that if the risk of PE is low, the filter should be removed if it's in a safe setting. So what that means is, we'll kind of get into it, but all of that kind of leads to we should be taking all the filters that we place out. So the reason that we might have some experience while we might not be retrieving these filters are the complications involved with filter retrieval. So this is a meta-analysis that's from pretty recent that goes through the different complications and different studies that looked at them. As far as the standard technique, standard loop snare technique, it's pretty well tolerated. There's not a significant amount of complications. Usually they're all kind of akin to line placement, port placement, things like that. It's when we delve into more advanced techniques such as bronchial forceps, laser-assisted sheath, or hangman technique, where the complication risks go a lot higher and the type of complications get a lot worse, like leg fracture, embolization, IVC, extravasation, bleeding, arterial injury, or cable thrombosis. So these are a couple examples of some of the bad things that can happen with filter retrieval. The first one's of forceps retrieval that resulted in extravasation from the IVC. This patient was admitted overnight with a 7-point hematocrit drop. This is another person with preoperative CT showing the hook of the filter in the proximal renal artery. Despite that, forceps removal was done, and the patient then had subsequent right flank bleeding and right renal infarction that improved with an amplastor plug placement. This is another one where a hangman technique was employed on an option filter. And, if you do enough of these hangman techniques, you kind of know about where to place the hangman under the struts. And if you kind of see, these are small pictures, but there's only under about one of the legs. So this filter eventually embolized into the left renal vein, causing acute left renal vein thrombosis. Another hangman technique, ex vivo, they noted that the two of the struts were missing. So they analyzed the chest and found that one was in the pulmonary outflow, one was in the right atrium. They couldn't remove the right atrial strut, and this patient eventually ended up developing tricuspid regurg. This is a recent case from one of my partners. It was an embedded filter that they couldn't get out until they used actually a cutting balloon and a forceps. Afterwards, the patient had a significant amount of pain. They found to have a dissection of the right renal artery that causes infarction of 50% of the kidney. So when you take all these into account, then you can look at the different risk factors when you're trying to assess who should get a filter retrieval, whether it's the tilt associated with the filter, the tip is embedded in the IVC wall, there's significant penetration or prolonged dwell time. Now, all of those are risk factors that we think about, but there's a lot of controversies associated with them, whether they actually are associated with complications or failed retrieval rates. So this is a meta-analysis I looked at that basically just goes back and forth on whether or not degree of FILT is actually associated with success or failure or complications for each of those factors. So basically, they kind of suggest that failed retrieval time can be from prolonged dwell time, while others suggest that they have no effect on it. The only significant thing I saw in this was just that they said preoperative CT was beneficial in decreasing complication rates for evaluation. So looking at the more current literature for IVC filter retrieval, I think it kind of starts from the circulation paper that a lot of people cite from. It basically looked that the cable penetration rate of IVC filters is 19%. A lot of people since this time have critiqued this specific article, saying that their definition of cable penetration was a little conservative. Most people suggest that penetration of the struts from an IVC filter reached probably 30% or even higher when we place any of these filters, which we commonly see on these CTs afterwards. So their recommendation, which has been used since then, is that these filters should be removed if there's any evidence of penetration, and particularly in symptomatic patients. This is from the Northwestern group reviewing their experience with these struts that are penetrating. You can see some evidence that they put in here of arterial injury that was embolized, some within the aorta, and then ones into the iliolumbar veins with occlusion that they reconstructed. They published on their penetration results within the aorta and with one in the right common iliac artery, and they had 17 patients. They had 30 or close to 30% with back pain, with 12% with PTS. They found 100% technical success in removing these filters with penetration into the aorta and the iliac artery through these different techniques without any major events. The good thing to note about this is they kind of planned arterial interventions for all of these, given the catastrophic results of removing from the aorta. They found that they actually didn't need to use that as often as they kind of employed. This is another group in Michigan that looked at their experience with filters. They found over a 3-year stretch, they placed 500 filters, 300 retrievable, and only 60 were retrieved. So that's a 20% rate. So I think that's alarming, but it kind of just tells you what's still going on in the community in 2018 or even now, that the retrieval rate is still extremely low. And they just noted in their study that there was a lower complication rate between the patients who had retrieved filters rather than non-retrieved filters, and particularly the patients who had retrieved filters had less thrombotic complications. And important to know, those thrombotic complications were early, 2 to 3 months after filter placement, suggesting that if you're removing these filters after that, you might have already lost the benefit versus the risk in filter retrieval. This is from the UCLA group. They looked at their experience with filters in 2020. They found that their rates of complication with filter placement are pretty akin to the rest of the nation in terms of IVC thrombosis, DVT, and filter migration. And they found that the complications associated with retrieval were low compared to the actual complications of the filter. And overall, their technical success, like these other papers, are very high. And this all just leads back to our largest prospective multicenter trial, PRESERVE, that recently came out. And they basically took close to 1,500 patients from over 50 sites, and about 90% of those patients received retrievable filters. The things that I kind of take from it, that the filters actually had not as many adverse events as you'd assume that are published in literature. They had migration, embolization, and penetration, but at particularly low rates. But of the patients they retrieved, it was a 98.8% successful rate after the first and second, and the adverse events related to those was very low, under 2%. So it suggested that all these filters that are retrieved are pretty successful and pretty well tolerated in terms of retrieval. So in summary, it's still a case-by-case basis whenever you're trying to determine to retrieve a filter from somebody, but all of our data still suggests at this time that there are a lot of detrimental things to having a filter in somebody. So everything should be employed in terms of retrieving the filter, particularly in settings where there are perforated filters or filter fragments that have embolized. Also in areas of symptomatic IVC occlusion, where we can reconstruct the IVC after removing the filter. And there's also such a big emphasis, I think, still on developing responsibility with placing these filters and making a physician-patient relationship with following up with these patients to really increase those retrieval rates. And that if any advanced retrieval techniques are required, they should be done with caution. There's still complications that can happen, but it's pretty well documented that can be done safely in the hands of an experienced operator or at the appropriate referral center. That's it. Any questions?
Thank you.